Hello friends, welcome to Srinetralay. Refractive surprise is one such situation where patient will not be happy with high refractive power after a cataract surgery. This particular gentleman was operated elsewhere and had a refractive error of -3.75. He was not happy for having a low vision for distance. So we had to plan a IOL exchange. This surgery was performed 2 months back. A hydrophobic IOL was used in the bag. So to start with the surgery, a 2.6 mm incision is made and visco is injected into the anterior chamber. A side port of 23 gauge is again created. Once the AC is well formed, I want to confirm that this IOL is not stuck in the bag which I have examined in the pre-operative examination on slit lamp. But to confirm it, I am just lifting the IOL and pushing the air below it so that if there is any vitreous or any attachments, I will be able to see it in a better way. Once confirmed that the PC is intact and there is no issue, I have injected a viscoelastic in the bag, lifting the IOL. A well-formed AC is mandatory while performing this to prevent the damage to the endothelium and to the bag. A bimanual delivery of IOL into the anterior chamber from the bag is done with the help of two Sinskey hooks, and bimanual use is very important. Now we have the IOL fully in the anterior chamber and AC is well formed. To perform IOL exchange, we need an instrument which is very small and still effective, like a ultrasonic needle by Dr. Neha Dholakia, which uses ultrasonic power to cut the IOL into multiple pieces with ease. A side port is slightly extended so that I can introduce the IOL stabilizing forceps through it and stabilize the IOL while cutting it with ultrasonic power. AC is well formed with viscoelastic and we have a firm grip with left hand IOL forceps. This IOL holding forceps is slightly stout at the tip. And now we can introduce our ultrasonic cutter into the anterior chamber and use the ultrasonic power to cut this IOL into pieces. Here the power used to cut the IOL is 40 with vacuum 0 and a flow rate of 250 so that AC remains formed while performing this maneuver. Once the two pieces are done, the first piece I would like to take out so that I get more space for maneuvers following. Please note that there is no need of any extension of the incision that can cause astigmatism tomorrow. The first piece is delivered out. This was a planned surgery, so all the instrumentations were ready and I was having my cool to operate the case comfortably at my leisure time, and all the steps were done meticulously with ease. Once the first piece is out, anterior chamber is well formed with viscoelastic again. Now the remaining piece of IOL is well positioned so that we can have a good grip of IOL before cutting it with the cutter. Holding the IOL with the left hand is very crucial, and the firm grip will not allow the IOL to tilt and have an angular cut while cutting with the ultrasonic cutter. So if you have a larger length of IOL optic to cut, it is better idea to cut it half, leave it half and then reposition the left hand again so that you can go farther and cut the remaining IOL in the second go. Here you can note the IOL is cut with a single attempt, and because of which the IOL cutting line is not straight, rather it is slightly curvilinear. There is no harm with that, but you need to take care that you are not damaging anything peripherally. The ultrasonic power here I am using even in the periphery does not cause any damage to the tissues per se, because it is a very sharp and a very small tip which is there, which do not dissipate the ultrasonic energy to the anterior chamber or to the endothelium that will cause damage. Now we have two pieces of IOL again in the bag. The second piece of IOL to be removed is aligned properly while removing it with the microforceps, and it is pulled out. The third piece is so small that I can easily pull out directly, and there is no need of any further dividation of this particular IOL. This completes the IOL removal process. Now we have to implant the IOL in the bag. Before proceeding that, I would like to form the anterior chamber with the viscoelastic, check the status of the posterior capsule and the CCC margins. I have an extra 3-piece IOL in hand if at all needed, but here everything was very smooth, so I went ahead with the implantation of a single piece hydrophobic IOL with a correct power. Once the IOL is dialed into the bag, I would like to check the position of this second implanted IOL in the bag with covered CCC margins, because pupil has become small now. The side port was slightly larger and was leaking, so I have used a 10-0 nylon suture to secure the wound, and this is followed by viscoelastic removal with IA. I have used this particular instrument for nucleus cutting also in hard cataract, and it works wonder. And we get the same advantage of not dissipating the energy while cutting the nucleus also with this needle, so that you use a lot of ultrasonic energy per se on the machine, but there is hardly energy delivered to the surrounding structures, and that do not cause any endothelial damage while performing a pre-chopping with this ultrasonic tape. Those who are not aware about the ultrasonic pre-chopper method of mine, which I have earlier posted, can see my videos on channel where I have posted this particular tip to use as an ultrasonic pre-chopper, and it works wonder to cut the hard nuclei into multiple pieces, and it is very easy. Hope you enjoyed this video. Do subscribe to a YouTube channel Dr. Pankaj Landai for more such exciting videos. Good day.